IBD today, specifically the diagnosis and management, and I'm going to try to go through what your MKSAP says are key points for boards, and then we'll talk a little bit about like the advanced therapies and then biologics. The goals are to go through epidemiology, risk factors. We'll talk about the clinical presentation because the MKSAP really has focused on how these things present more so than the nitty-gritty of treatment, but we'll also talk about treatment. Extraintestinal manifestations are big on your board, so we're going to go through some of those, maybe a review, but I think it's important. And then for Crohn's and ulcerative colitis, we'll talk about medical treatment options, and then medication side effects, which are particularly important for the boards. And then we'll talk about surgical treatment in IBD, and then we'll talk about what primary care can focus on when they are dealing with patients with IBD, specifically with health maintenance. And if we have time, we'll do some MKSAP questions. Hopefully we do. So first we'll start with a case. This is a 28-year-old female with no significant past medical history, coming in with 4 months of constant right lower quadrant abdominal pain, intermittent bloating, and nausea. She also notes loose stools with occasional bright red blood, no NSAID use. She has a 10-pound weight loss, no travel history, no family history of IBD. She smokes. On exam, she's thin, but otherwise, aside from some tender right lower quadrant pain or tenderness and mild distension, she's otherwise benign exam. Labs are notable for a mild anemia of 10, a microcytic at 78, somewhat high platelets at 402, and CRP is a little bit elevated at 1.9. She undergoes infectious workup of the stool with C. diff and cultures negative, as well as Giardia. And then fecal calprotectin, which is a gut-specific marker of inflammation, is high. I think 200 or 150 is the upper limit of normal. She undergoes a colonoscopy. It shows patchy ulceration, erythema in the cecum, and a narrowed ileocecal valve and a terminal ileum. And then the terminal ileum is notable for multiple ulcers with underlying erythema, consistent with ileal inflammation and right-sided inflammation. Pathology from coming back from the biopsy shows active ileitis and colitis with crypt distortion, crypt abscesses, and granulomas. So IBD. So just a little bit quickly about the epidemiology. I think most people have been informed during med school that there's a bimodal age distribution where there's a diagnosis in the 20 to 30 range, and then again later in life in the 50s, 60s. Not a common disease, maybe 2 to 10 cases per 100,000 person years in North America. And the incidence is pretty similar to UC and Crohn's. There's also a rising incidence in the developing world and a lower incidence in the Middle East. Some risk factors, and Ashkenazi Jewish descent, genetics does play a role, although if you take each gene and then you add up the total risk, it's still small. Smoking does increase your risk of Crohn's. It's protective in UC. It's not the nicotine, it's the smoke. They've delineated that in some studies. And then suggested is that the Western style diet may have something to do with the increasing incidence of IBD in the developing world as they move to our diet. NSAIDs, the absolute risk is small, but NSAIDs can cause a separate ileitis or colopathy that can look like IBD, so it's important to think about. And the jury is still out in regards to the microbiome. There's a lot of stuff going on in terms of research there. Obesity, which is a risk factor for pouchitis, inflammation. Breastfeeding, oral contraceptives, appendectomy, and sleep deprivation are all possible, but we are not sure. So I think it's important from an internal medicine standpoint to know how these diseases progress. Specifically with Crohn's, it's a chronic disease characterized by intermittent relapses or flares, followed by periods of remission. This is without medical therapy. Without medical therapy, you might see more severe course, but patients can still regress over time, just as far as the natural history. 10 to 20% of these patients, so not common, but there is prolonged remission in some patients not on therapy. And then half of the patients with Crohn's do develop complicated disease like a stricture or penetrating disease, which is also known as a fistulizing disease. And risk factors for that, which are important when you're treating these patients in terms of, are they likely to develop bad disease? So do you need to treat them with something stronger early? Some things that we use are the earlier age, less than 40, smoking status, perianal or distal rectal disease involvement, low socioeconomic status, patients who've required steroids in the past or who have extensive disease throughout a lot of their bowel. 80% of these patients will require hospitalization, and many require surgery. I've seen up to 60% with Crohn's disease. But the mortality still seems to be similar to the general population. That's I think important for these patients to know, whereas UC is probably going to be the same, similar to the general population, but maybe slightly more mortality. For UC in general, patients usually have, without treatment, chronic diarrhea, chronically bloody. Rarely do they have pain, so this is more of a bloody diarrhea type of symptomatology. And with treatment, you do tend to see long periods of complete remission. Where despite the fact of, you might have 2-3 years, 66% or so of these patients will relapse and require steroids or step up of therapy. And factors that predict or are associated with a higher risk for progression or poor response to weaker therapies include a young age of diagnosis, an extensive amount of colitis that goes rectum proximal to the splenic flexure or extensive colitis, pancolitis, which is throughout the rectum all the way to the cecum, and then on the flip side, early mucosal healing is a positive predictor for prolonged remission, and that's I think that's something to know for your patients. So I think it's also important to talk about definitions that you might hear, since this is a very commonly an outpatient disease, so some things we don't see on the wards during residency, like more limited ulcerative colitis. So first of all, ulcerative colitis versus Crohn's. Ulcerative colitis is usually just a superficial mucosal inflammation, whereas with the Crohn's, it's actually maybe an outside to in inflammation that can maybe start in the serosa or even the adipose tissue of the mesentery and then move forward. So some patients with normal-looking intestine on colonoscopy may actually have increased enhancement, signs of inflammation on a CT or MRI scan, which we're seeing that more with Crohn's in particular. So there's proctitis, which is just rectal disease, ulcerative proctosigmoiditis, which is rectum and sigmoid. Disease that goes to the splenic flexure but doesn't go proximal to that is left-sided UC. And then extensive is if you go proximal to the splenic flexure. And then pancolitis is from the rectum to the cecum. As far as Crohn's disease, I think we all know it's characterized by transmural inflammation and skip lesions and can involve anywhere in the gut, including the foregut. We do use this classification called the Montreal classification. It just goes by age, location, and behavior, and if there's stricturing, penetrating, or perianal disease. But we don't need to know the specifics. And then the last entity is indeterminate colitis. So indeterminate colitis is basically colonic inflammation where it doesn't quite fit the picture of UC, doesn't quite, maybe moving towards Crohn's, but we're not sure yet. There's no serological testing to help us with this, and this is a minority of cases, but it is not uncommon, like 10 to 15% of the cases. But we do treat this sort of similar to other IBD colitis. So MKSAP talks about what's important with UC, and although it seems a little basic, they do want to harp on the fact that diarrhea and rectal bleeding is the common UC presentation, leading to anemia commonly. The other things to think about when patient presents is if they're going to the bathroom, they feel like they need to go, but they can't go. They call it constipation, but they're feeling this urge, and then they try to sit down and they don't go. That's tenesmus. And that's caused by rectal inflammation leading to cramping of the muscles and the feeling like you need to go. And that's why they don't have any stool in the rectal vault, but they still feel like they need to go. Fecal incontinence, rectal pain, and urgency are all common symptoms of UC. In terms of stratifying these patients to help with therapy, UC can be classed into mild, moderate, severe, and then acute severe UC. Mild being 4 bowel movements or less, minimal systemic findings of white count, fever, and then absent abdominal pain or tenderness. Moderate UC, you may see, you're going to see more than 4 bowel movements per day, less than 6, so 4 to 6. Mild anemia, and then the absence of severe abdominal pain or systemic findings. Severe disease, you'll have more bowel movements per day, severe abdominal pain, and systemic toxicity. And when we talk about these, you just sort of need one to jump you up in category. So if you don't have any abdominal pain, you don't have any anemia, but you're going to the bathroom 10 times per day and it's due to your UC, and it's not confounded by another cause of diarrhea like a bile acid diarrhea or some other sort of diarrhea, fat malabsorption, then those patients will hit the higher level. So we'll take that into account when we treat them. So somebody that has 8-10 bowel movements per day, we're not going to treat them for mild UC for the most part, unless they have such mild findings on colonoscopy that it sort of is like, well, maybe we should just try that therapy first. And then there's something you'll see on wards, and we'll talk about this in a little bit, acute severe UC, and we go by the True Love and Witz criteria, which is helpful for prognosticating these patients. And it defines acute severe UC. It's an acute disease involving the colon, and you'll see systemic findings like fever, tachycardia, abdominal tenderness, severe anemia, elevated inflammatory markers, and weight loss. If they're distended or have rebound tenderness, you want to immediately think perforation in these patients from toxic megacolon or severe colitis. And these patients are, once you have this class of patient, you have a time clock that you start. So when they're in the ICU or they're in the step down, these patients really have about 7 to 8, maybe a couple more days of medical therapy before which, after which you need to take out their colon. In terms of Crohn's, as opposed to UC where it's runny, bloody diarrhea, Crohn's will often present with pain, abdominal pain, weight loss, and anemia. But given the fact that Crohn's can be located anywhere, it can also present with symptoms similar to UC or can present with any symptoms. I want to note that in stricturing disease, patients may come in complaining of intermittent constipation and bloating and nausea, and it more sort of seem like maybe an upper GI etiology is going on, but these patients just have a stricture or a narrowing in their ileum and can't pass from time to time because of a partial bowel obstruction. And then one thing I don't think we see a lot of on the wards, but you know, in GI we see a lot because these can often be managed as an outpatient, are fistulizing disease. Specifically, if you have an abscess from fistulizing disease, you may be somebody that presents with slow onset of symptoms and you're not toxic, no acute abdomen. So sometimes these are just, they go right to IR from outpatient. They don't necessarily need an inpatient admission. So the different types of fistulas, you can have pretty much a fistula from the gut anywhere. So enteroenteric, and these can present with a mass from fluid collection. Enterovesicular fistulas to the bladder, which can present with polymicrobial UTIs, recurrent UTIs, pneumateria. You can have a retroperitoneal fistula, in which case patients present with a psoas abscess or ureteral obstruction with hydronephrosis requiring drainage. Enterovaginal fistula, where they'll present with the passage of gas or feces through the vagina, and then enterocutaneous fistulas, which is some sort of purulent drainage after a hole in the skin the patient notices, like with drainage. Sometimes they're very small, so the patient will just note drainage, and when you do the physical exam, you were thinking this may be like a boil or a carbuncle or something, but actually it's a fistula. So this is a nice CT image. you can see where the arrow is, that line shouldn't be there of bowel. So that's connecting from small bowel to, I think, the large intestine there. And the treatment for that is biologic therapy, surgery, and then sometimes, if it's the right candidate, endoscopic therapy. And I'm going to show a couple pictures later on of some of the cool things that we can do endoscopically for these patients to avoid surgery. And these patients actually do really well if they're candidates and have successful endoscopic therapy. This is a picture of a retroperitoneal fistula. You can, with an abscess. You can see that nice big abscess in the middle, anterior to the vertebra. And this is similarly treated with biologic therapy, endoscopic therapy, but in the acute setting, you want to drain these patients like you drain any abscess with IR and then antibiotics for a short period, followed by anti-inflammatory medications. And then your MKSAP talks a lot about extraintestinal manifestations of IBD, and they show pictures. I remember from my boards that there are a couple of extraintestinal manifestation pictures, so we'll go over that in a second. But the common ones in IBD are aphthous ulcers. You need to ask about arthralgias or joint pains, back pain, eye symptoms, and skin involvement. And for whatever reason, they seem to be more linked with the colitis involvement of Crohn's or UC. So we'll break this out here. Can anybody tell me what this is with painful nodules, usually on the lower extremities? Okay, good review. And that tends to mirror the IBD activity. So if you treat the IBD, this tends to improve. Pustular and violaceous plaque with incipient breakdown. PG? Yes, okay. Pyoderma gangrenosum, good. And that one is, it's probably independent of IBD activity, although some recent data shows maybe it does mirror a little bit, but I think independent of IBD activity is what I'm going to go with. And this one, a little bit harder. Redness, itchy, irritated single eye with no visual changes, no blurry vision. Sorry? Episcleritis, good, yeah. So you can see that the sclera doesn't look very involved. It's still white, it still looks healthy, and then there's this increased injection on the outside of the eye, and that is episcleritis. And that one mirrors disease activity. It's not an eye emergency, unlike two of these guys. So this one presents with eye pain, redness, but you do have blurry vision or visual change, and these are two different ones. Can anyone tell me what number one is? Sorry? One of them is uveitis. So the second one is uveitis because it's hard to see, but you don't see that injected sclera here. You sort of just see more diffuse. But I don't think they'll give you, one or the other. They'll probably just give you the one that's the one that's causing visual changes. So that'll either be scleritis or anterior uveitis. And both of these are independent of IBD activity. And this is the last picture I think I have for the extraintestinal manifestations. You have a diagnosis of UC, they have chronic elevated alk phos, and this finding on MRCP. Okay, correct, PSC. So I'll say that those wider appearing bile ducts or biliary tree, that's more normal, and then you see these kind of like very narrow ones. Those are the narrow ones. So the normal is the nice thick ones. So it's not that they're dilated, it's that they're the beating strictures, and that's also independent of IBD activity. And then we'll talk about joint involvement, and I'll just be brief in the interest of time. So when we think about axial involvement in back pain, sacroiliac pain, it's inflammatory. It gets better with exercise. It's worse in the morning or with rest for more than 30 minutes to an hour. These patients tend to have an independent course, but sometimes their back pain can start as an initial manifestation of IBD. So, and treatment of the IBD doesn't necessarily help with the back pain, so we work with our rheumatologists in these patients. Joint involvement is also not very uncommon. It happens one out of every 20 or so patients that you see. And then there are two types of arthropathies. There's the polyarthropathy, is what I'll say, that it does not parallel disease activity, and that can look more like a lupus or a RA. And then there's type 1 arthropathy, which parallels disease activity, and that's a non-erosive disease, more oligoarthritis or arthropathy, and can involve the large joints. And so when you're diagnosing IBD, the more I learn about IBD, I feel like the harder it is to diagnose IBD because there's so many things that can look like it. Once you've excluded all those things, be it medications, be it vascular, be it infection, that's when you can call it idiopathic because IBD is a chronic idiopathic disease. The most important thing to do in the hospital or in clinic is to exclude infection. Usually infections will be more acute or subacute versus IBD, they'll be chronic, but that's not always true. Like in Giardia, you can be infected for months with this slow, smoldering diarrhea. So you need to rule that out. You need to rule out enteroinvasive bacteria with stool cultures like Salmonella, Shigella, E-Tech, Campylobacter, and then of course C. diff. All of these can mimic colonic IBD. And then if there's a travel history, you need to get a stool O and P. Because things like Entamoeba histolytica can look exactly like right-sided Crohn's disease, like of the cecum and the ascending colon with ulceration. Yersinia can look like terminal ileitis, so it can look like Crohn's that way. And then, of course, TB can involve basically anywhere, so you can get an ulcerated, inflammatory area basically throughout the GI tract. So in patients with travel history or from endemic areas, we need to consider that. If they're immunosuppressed from other reasons, chronic steroids, chemo, then they're at risk for a CMV or an HSV colitis, and those have to be diagnosed through biopsy. So basically any immunosuppressed patient with a subacute diarrhea, 3 weeks or longer, needs a scope to make sure that you can biopsy and rule that out. And then patients with appropriate history can get a distal like proctitis from chlamydia or gonorrhea, or syphilis, which can mimic most diseases like TB can. Ischemic patients, so ischemic colitis is also new differential, and that's in more patients who have more acute abdominal pain, diarrhea with colitis. And those patients tend to be older, and they tend to have risk factors for vascular disease, your classic ones. And then there's other types of non-IBD inflammatory bowel disease, not Crohn's or colitis, but there are still inflammatory bowel disease, and that's like Behçet's, radiation colitis, and then there's non-inflammatory or non-immunologic like diverticulitis and appendicitis. This is a nice picture. We actually saw one of these. We scoped somebody in the step down a couple weeks ago, had rectal bleeding on heparin, and also had C. diff. So we went in there looking to see if there's something we could treat, and they just had this cottage cheesy, white, curd-looking colon, and this is classic pseudomembrane. We biopsied it, and it was pseudomembranous colitis that you see with C. diff. Also a common thing that we see when we scope patients with symptoms of IBD are an NSAID-related enteropathy. I think I talked about it earlier. And that'll be more sort of, you'll see these aphthous ulcers, which the rest of the mucosa will look sort of normal, and these are more well-circumscribed ulcers. And we'll have to exclude NSAID enteropathy by stopping the NSAIDs before making a diagnosis of IBD. Cocaine, chemotherapy, specifically we're seeing a lot of ipilimumab and nivolumab induced colitis patients. Those are treated like IBD patients now. And that can be a quick thing where it goes right away. You don't have to treat them on maintenance, or it can be something that rarely but can progress to look just like now their checkpoint has been inhibited, and for some reason now they're developing IBD that's chronic. And those are tough cases. Oral contraceptives, and then also malignancy. So this is a nice picture of malignancy, although it would be difficult to say this is not severe colitis or enteritis, but this I think was a lymphoma case in the colon. And biopsies came back showing sheets of cells and not cryptitis, crypt distortion, things that you would see with IBD. So the workup, I think most people are familiar with the workup. I'm going to highlight, you do basic labs, iron studies, screen them for nutritional deficiencies with vitamin D and B12. Calprotectin is more of a newer test. I think until last year they didn't even have it orderable in patients, but it's very gut specific. Patients that have a normal CRP can still mount very elevated fecal calprotectin levels, and that can be good for both diagnosis, where if they don't have other red flags, now they've got this high fecal calprotectin, so we'll scope them and have a look to see if they have IBD. The other thing that you can use is the fecal calprotectin. It can normalize with treatment, and then down the road they develop a flare, and you can say, okay, your fecal calprotectin is normal, and this is probably something else like IBS or some other cause of their diarrhea. So it's a really nice, useful test for gut-specific inflammation. Antibody testing has been proposed as something that is useful with diagnosing IBD or telling us if we have it, but really there's no clear utility yet. Those are like the ANCAs, or a couple of other ones. MKSAP focuses on the fact that given the nonspecific symptoms that you see with IBD, you need to visualize the colon or the intestine or wherever the inflammation is to make a diagnosis. So that's what I'm putting on here, although I know you guys know that. We also use enterographies to stage disease, or specifically with Crohn's disease. This can be very helpful for planning interventions as well, because if you have a stricture, defining how long it is can make it so that they are endoscopically intervenable, or they're not and they need to go to surgery right away. And then also part of the workup is if you have a sick patient, you want to get the ball rolling with metabolite levels for azathioprine or 6-MP therapy, and then hepatitis B and TB, because reactivation of Hep B and TB are important side effects of some of the stronger immunosuppressive medications that we use. So I think I mentioned this, that because of the nonspecific nature of IBD, we want to visualize the GI tract. MKSAP also wants you guys to know about the radiation concerns with IBD, specifically that because a lot of the IBD patients are young and they need recurrent imaging, that they have a pretty real risk of long-term issues from radiation therapy. So if you can, always try to get a radiation-saving technique like an MRI. And MRI enterographies are very good here. So I think it's also nice to know what normal looks like. Sometimes we'll post pictures of inflammation, which can be obvious or it can be subtle. These are normal colons. So you can see that nice pink colonic mucosa. You can see the vasculature. When you start to not see the vasculature, that's a sign that there's inflammation going on. In the sigmoid colon, you don't always see the vasculature, but these are right side and transverse, and then the proximal left side of the colon, you'll see the nice vasculature. You'll see a nice pink mucosa. You won't see really strong red, and you won't obviously see ulceration. These are abnormal. So common findings are ulceration, granularity. Let's see if I can use this mouse. This is like a nodular formation, so this might be normal tissue that got compressed from the surrounding inflammation, and that's called cobblestoning. And then here, this one didn't come out as well, but this is just highly deformed, friable, and ulcerated mucosa. We call them like serpiginous ulcers. And then this is sort of the progression of Crohn's. So the A is the earliest sign that we will see if we catch it. It's an aphthous ulcer with a little bit of surrounding inflammation. Here, the ulcers are deeper. You see a little bit of cobblestoning forming where there's some areas of normal tissue with these deep ulcers. Here now you have pseudopolyp formation with severe ulceration amongst normal tissue. And then here you're starting to see some narrowing of the lumen, and this is consistent with like a severe starting to stricture disease. Okay, now we're going to talk about the management of IBD medically and a little bit of the other things. And this is a very complicated process. It requires complex decision-making on our side, but also on the patient side. So it's important to educate your patients, give them as much as they can take, and then sometimes give them readouts to take home with so they can make the best decision for them. Because a lot of these therapies are first line, and the patient has to be able to take them sometimes inject themselves, and just make sure that there's a good compliance with whatever medication you give, because these are very expensive medications. So we do take into account the patient preferences, the severity of symptoms. So like I said, mild, moderate, severe, we're going to give a biologic to anybody who's in that severe category, in the moderate to severe category as well, but the mild, we may not do that. Endoscopic disease activity, so if they have mild symptoms but they have really nasty looking disease on endoscopy, they might be somebody that we would recommend considering a stronger medication. But if the patient says, hey, you know what, I read about the side effects, I'd like to try something else first, you want your patients to take what they're going to give you, or to take what you give them. So you may do something a little bit less intense at first based on a discussion. And then we try to prognosticate these patients as best we can. So in somebody with multiple risk factors for disease progression, and we talked about it earlier, but young age, extensive disease involvement, smoking, deep ulcers, requiring steroids, and there are different risk factors for Crohn's versus ulcerative colitis, but they do overlap. If they have a strong risk of progression despite just like mild to moderate disease, we might say, you're at risk for needing surgery down the road. Why don't we think about a biologic for you? And then there's this concept of induction versus remission. So some medications like steroids, you really only want to give for a short period of time, for a few months maximum, and due to their side effect profile. So you want to induce remission, and remission is complicated right now, but it's a little controversial. But there's clinical remission, and then there's endoscopic remission, and then there's histologic remission, which is deep remission. And which target you're treating to is a little bit up for debate right now. But induction of remission is the first thing you want to think about, and then you move to a maintenance therapy medication, and we'll talk about those in a second here. So UC and Crohn's are different entities and respond to different therapies, although there's a lot of overlap. So that's why it's important to get that diagnosis right. So if you have less than 4 bowel movements per day, minimal systemic symptoms, no abdominal pain, no anemia, then you're at this mild to moderate UC category. And let's say we've stratified them and they have a low risk for progression, then we're going to talk to them about medication with less immunosuppression. So that would be a mesalamine or 5-ASA. And these are topical anti-inflammatories, meaning that they get released somewhere in the intestine, and depending on the formulation, they're going to either be released in the distal, in like the terminal ileum or the ileum, and then also the colon, or some just go through the colon. And then you want to think about where is the disease. If it's predominantly left-sided, you might be able to get away with doing just a per-rectal enema or a suppository, versus if it's extensive proximal to the splenic flexure, they need oral therapy. The other thing that MKSAP wants you to know is that there are some side effects, and they're commonly tested. And you want to discontinue the medication if you see them. For things like mesalamine, sulfasalazine, the big ones are interstitial nephritis. It seems to be coming up, so you'll see like a patient with a slowly worsening chronic renal rising creatinine, and maybe they have some EOs on a urine EOs test, and maybe they have an eosinophilia, and these patients have interstitial nephritis. Then pancreatitis, pericarditis, and pneumonitis are all hypersensitivity or sensitivity reactions that you can get to these 5-ASA medications. So this is just a table. So sulfasalazine is like the old formulation of 5-ASA, and then the newer agents like mesalamine, like Aprizo and Lialda, are like the newer ones that we use. So for sulfasalazine, it's a slightly dirtier drug. It can cause male infertility or oligospermia, so that you can just stop the medication, and that's usually reversible. Then your normal medication side effects like nausea, headache. The newer mesalamine medications can cause a watery diarrhea, so it's important to think about when you start this medication. The patient says, I was doing well, and now I'm having watery diarrhea all day, every day. You scope them, and they look like they have an improvement. This is when you start to think about mesalamine-induced diarrhea. Uncommon, so 1 to 10% of the time you can get anemia, hemolytic anemia, thrombocytopenia, pancreatitis, like a fever rash reaction. And then rarely you can see things like agranulocytosis, pancreatitis for sulfasalazine, and then interstitial nephritis, which I wanted to highlight. So now we've talked about the side effects of the mild to moderate therapy. We'll say we started them on this, and then we put them on, give them a couple of months, and they're still not doing better. We've ruled out an infection. So now we have to think about steroids because these patients are refractory to 5-ASAs. So we start a taper. So unlike a COPD exacerbation or something else you would use steroids for, IBD flare treatment is a long, at least 6 to 8 week duration of steroids. So it's usually around 2 months that you're going to be putting these patients on steroids. There's a big landmark study that showed that 40 milligrams is not worse than 60 milligrams, and it obviously has less side effects. So we generally start now with 40 milligrams. That's not always true. If someone in the past has not done well with 40, we may be higher doses for them. Then there's another medication that's newer. So I know you guys have heard of budesonide, but there's a formulation called the MMX. It's like a matrix that gets spread out over the entire colon versus the initial budesonide is just more of a right-sided ileocecal type of distribution. But budesonide is nice because it's not systemic. It has a high first-pass metabolism, and this is an option for some of these patients too if their insurance covers it. And it's just as good as prednisone. Like I said, it's a long taper. We'll start at 40. We'll do that for about 3 weeks, and then we'll go down by 5 milligrams every week. So now you guys know how to do this for the wards. If the patient goes into remission, you can keep them on their 5-ASA, but if they don't, you can't keep them on the steroids. So you're going to have to go up in care in their treatment. So let's say they don't respond to the steroids, or they can't get off steroids, or they initially had moderate to severe disease by clinical or endoscopic definitions. Now we think about biologics. The most common biologics are anti-tumor necrosis factors, which is like infliximab or adalimumab. So Remicade and Humira are the ones that are most commonly used. And then anti-integrin therapy. And again, this is for UC. So these are your options for UC. I got to go a little quicker, but vedolizumab is one, and then tofacitinib or Xeljanz was recently approved. I'll be quick with the side effects, but infection and malignancy are the most common ones. Xeljanz was recently, they just recently put out a warning that with the high dose you can get pulmonary embolism, so it's something to think about in the next few months here for you guys on the wards. And then hypersensitivity reactions. And then there's this risk of zoster, which is why we try to get these patients vaccinated. And then tofacitinib or Xeljanz has the highest risk for that. So this looks funny. Okay, so the acute severe UC, so this is a patient that comes in that met criteria for systemic findings. I'm going to be quick here, but the main thing you want to do is rule out infection first, call GI. These patients need to be, once infection and C. diff are ruled out, you put them on high-dose steroids. So 20 milligrams of solumetrol Q8 is the recommended dose. There's some other doses you can use, but we use this. These patients should have a scope for biopsies and diagnosis, and they can rule out C and B colitis, because up to 30% of patients with severe UC flares can actually have C and B colitis, and that's a different therapy, right? That's getting cyclovir. And the main thing I want to tell you guys, so I can get through here, is they basically have 3 days of steroids. If they don't respond, then they get another 3 to 4 days of salvage therapy. That's rituximab or cyclosporin. And if they don't improve by day 7 to 8 or 9, these patients need to have a colectomy. So some tips for what to do here. These patients should be in step-down and MICU so they can be monitored. The GI fellow should be involved. We should rule out C. diff. And once C. diff is ruled out, you can start steroids if you're pretty sure this is a severe colitis flare. And then a lot of these patients at Metro, they don't know how many bowel movements they've had, so it's good to put them on like a monitored an order so that you know, because if they have more than 8 at day 3 bowel movements, that's predictive of requiring colectomy, and just going right to salvage therapy like cyclosporin or rituximab so that's one of the big predictors, that one in a CRP that either doesn't go down or is greater than 20 at day 3. And then we talked, surgery is important to get on board early in the first few days. So Crohn's is a little different. So for induction, steroids, budesonide, prednisone, and the goal is to get off of these by 2 to 3 months. And then you can consider for mild disease 5-ASA, something with ileal involvement. You can do something like they've got formulations that get released in the ileum now. And then but the sulfasalazines, those are cleaved from the pH change that happens when you get in the colon. So those you really shouldn't use in small bowel Crohn's. So mild disease, it's going to be similar, but you need to make sure that you're doing something that is appropriate to the location of their intestinal involvement. For moderate to severe disease, it's similar to UC in terms of the biologics, but we also think about something called the dual approach, which is a biologic like an anti-TNF plus a thiopurine or 6-MP, and that has been shown to reduce immunogenicity or antibody formation and lead to a better response. I'm going to skip over the side effects for azathioprine, but the ones for the boards that are important are hepatotoxicity and cytopenias, so you watch the CBC and the LFTs closely at first, then every 3 months or so. In terms of the biologics, so we talked about anti-TNFs, we talked about the anti-integrin therapies, which are gut-specific, like betalizumab. Those are options for moderate to severe, and then Stelara or ustekinumab, which is an IL-12, IL-23 inhibitor that's been approved and has pretty good data for patients that don't respond well to the earlier agents like anti-TNF. So those are, actually you can even use those first line. And then there's a lot of options in the pipeline. There are at least 5 or 6 that are currently in phase 3 studies. So this is not as important for MKSAP, so I'll be quick. Stricturing disease, fistulizing disease, for the right patient, endoscopic therapy can be used. So this is a stricture here. On the left, this is a balloon that we blew up, and then this is the lumen afterwards. So if you have good control of the inflammation and you're able to manage these things endoscopically and avoid surgery, that's good, because if they require one surgery, Crohn's patients are more likely to require another surgery. So if we can do this, and we can. And then this is a fistulotomy endoscopically. So you can see there's in the top left, there's a nice, nicely placed guide wire, and it's actually coming out on the other side of the lumen, but also inside the intestine. So this is an enero fistula. And then we're using an IT knife or like a needle knife, which is like a little tiny knife with cautery. And we cut open the fistula and then connect it to the rest of the tract. So these patients have resolution of their symptoms, and with good medical therapy, don't necessarily need surgery anymore. And then I want to talk about the main thing I want to say about UC surgery, so a total colectomy with an ileorectal pouch anal anastomosis. So it's said that that's like curative, and it is from an inflammatory standpoint if they truly have UC, but some of these patients may have had Crohn's and can develop inflammation of the pouch later on. And then the other thing is this is 3 surgeries. Their new normal is not going to be normal bowel movements. It's going to be 6 to 7 mushy, loose stools per day. And pouchitis happens in 40% of these patients at 1 year. So, and that causes pain or urgency or diarrhea. So although it is curative, from an IBD standpoint, you don't want to take it lightly just taking out these patients' colon, because some patients especially that are not warned for what happens when they have a pouch, are not happy with their life, and some of those patients end up getting reversed from the pouch to just an endoleostomy. So what can primary care physicians do to optimize the health of these complex IBD patients? There's a large preventative health component. We can recognize medication adverse events, including lab monitoring. We can perform smoking cessation, because that's incredibly important for Crohn's disease and those in the prognosis of Crohn's patients. early recognition of worsening symptoms and then appropriate rule out of infections can be very helpful for management decisions. And then monitoring their nutritional status. If they're developing weight loss, looking at the labs like their fat-soluble vitamins, all the vitamins they can become deficient in. Patients with colon cancer and MKSAP will tell you after about 8 to 10 years from diagnosis or immediately if you have PSC because of the increased risk of colon cancer in PSC UC patients, you should perform surveillance colonoscopy every and the new guidelines from ACG just came out. They say 1 to 3 years. It used to be 1 to 2, but it's now 1 to 3 years with colonoscopy and this is for extensive colonic disease involving more than a third of the colon. For severe disease, we talked about the risk of malnutrition of vitamin, and then osteoporosis. So a lot of these patients will be on prednisone or some sort of steroid for weeks at a time, and if you've been on a high dose for over 3 weeks, then you need a DEXA scan plus or minus bisphosphonate therapy. For biologic initiation, so TB, all these patients have to have a documented TB test and hepatitis B testing before being approved from an insurance standpoint because they can reactivate. Patients will require a yearly flu shot, but that shouldn't be live if they're on biologics. And then the pneumonia vaccines, both the 13-valent and the 23-valent. So you give the 13 first, then wait 8 weeks and do the 23, and if they get the 23-valent first, they have to wait a year, and then a booster later on. And then with 6-MP agents, so like azathioprine or 6-MP, those patients have an increased risk of cervical dysplasia and need yearly gyne exams with pap smears, and then also non-melanomatous skin cancer is another big one. So they need derm. Or if you feel comfortable doing a full skin exam yourself, you can do that too. So back to our case, this patient was diagnosed with Crohn's ileocolitis. Given her age, her smoking status, and the amount of ileal involvement, she was started on biologic plus immunomodulator because of the decreased risk for immunogenicity. And her symptoms improved. She had a follow-up colonoscopy showing remission. And then she was vaccinated. She had her CBC and her LFTs checked for her Imuran or azathioprine, and then she had yearly pap smears and skin exams recommended to her. So in conclusion, proper diagnosis is very important because it affects the therapies that we can give, although there is overlap. There are therapies that we must take into account for patient preference with a large emphasis on joint decision-making for these patients. It's important to rule out infection before steroids, and then there's a large component of preventative health. And I do have MKSAP questions, but I don't know if I have time. Do I have time? No time. We want to do one? Okay. Let's do... Did you guys see what that was? Okay, let's do this one. So we have a 22-year-old female with a flare of Crohn's. A colonoscopy performed showed moderate patchy left-sided colitis extending from the descending colon to the splenic flexure. She responded to therapy with prednisone, but declined maintenance therapy in advance of conceiving. She's now 12 weeks pregnant and for the past 2 weeks has experienced bloody diarrhea and left-sided abdominal pain. On physical exam, seems like she's got good vitals. There's left-sided tenderness without rebound or guarding. Flex sig shows recurrent left-sided patchy colitis, and stool studies are negative for C. diff. Which of the following is the most appropriate treatment? Who wants to do it? C, controlled ileal-release budesonide. It's a reasonable choice, and now it might actually be a reasonable answer because I think there's pretty good data for budesonide, but it's not definitive that that's the best case because this patient has been flaring pretty severely here. So I think the thought is that you want to do something that is like a biologic. And certolizumab is an anti-TNF and is the is first line. The interesting thing, which for our boys, it has an FC component that won't cross the placenta. So certolizumab is the answer. But the main point is that any anti-TNF therapy is effective for induction and maintenance of remission in Crohn's disease and is generally considered pretty safe in pregnancy. Mesalamine? Yeah, so basically even azathioprine, which is technically a category D, anything besides methotrexate, the actual risk of poor fetal outcome and maternal outcome, if the patient has uncontrolled Crohn's or UC, is higher than the risk of the medication, which is a very low risk for these things. So generally, the strategy is to keep the patient on whatever is helping them. And that can be mesalamine, that can be the biologics, that can be azathioprine, it can really be anything. Does anybody have any questions about just IBD in general? Specific stuff? No? Do we have time for another one or no? Okay. Thanks, guys.